I'm so grateful to be here today to be able to introduce my colleague, Dr. Caroline Cox. It's very confusing. Dr. Caroline Cox. I do know my colleague's name. Dr. Cox is a graduate of the Perelman School of Medicine at the University of Pennsylvania. As many of you know and remember, she completed her OBGYN residency here at the University of Wisconsin. Go Badgers. And then went on to complete her female pelvic medicine and reconstructive surgery fellowship, now called urogynecology and reconstructive pelvic surgery at the University of Michigan. Go Blue? Yeah. Go Blue. All right. All right. She currently serves as the assistant program director to the residency. So in addition to her strong commitment to education in general of all levels of trainees, she's also very active in the societies, serving on the anatomy committee for the Society of Gynecologic Surgeons, and also serving with me on the philanthropy and development committee for the American Urogynecologic Society. So please join me in welcoming Dr. Caroline Cox to discuss the key role of the apical ligaments in uterovaginal support.
Good morning. Thank you to everybody who's here. It's so nice to see faces, and to everybody who's online as well. I'm excited to talk about this topic of the apex this morning. Some of you might be groaning that another urogynecologist is giving a talk on the apex, because why do we always talk about this over and over again? But hopefully today my talk is actually going to help you understand why we care about the apex so much. We are going to be talking about physics and biomechanics. Don't hear any excitement about that, but hopefully you'll get excited once you learn some new things. This talk is going to be a little interactive, so you will need your phones to answer some questions as we go along. So we'll get some variety of opinions of things. All right, I do not have any disclosures, but just FYI, pretty much everything that's in this talk comes from this review paper that I wrote with my mentors in fellowship. And really all the experiments that I'm going to be talking about in this talk came from University of Michigan. So I won't do too much of the GOBLUE, but there's a little bit of that. So learning objectives today: 1, to understand the anatomy and histology of the apical ligaments; 2, to integrate imaging findings and biomechanical studies of the ligament properties, and then understand how they relate to prolapse; and 3, to synthesize all of those findings into a conceptual model for the progression of prolapse. And I will add in some clinical pearls at the end too. So it's not all just science. So first I have some food for thought for you. So a couple questions to just ponder first. In your mind, what is prolapse? What causes prolapse? And then the hardest question, how do you explain these concepts to patients who have very little concept often of their own pelvic organs in the first place? So this is where we get to participate. Not working. It's okay. What if we just have some brave people shout out, what is pelvic organ prolapse? A hernia. What other words would people use to describe it? Laxity. Anything else? I heard annoying. I heard, wait, something of the pelvic floor. Weakening of the pelvic floor. Okay. That's lots of good words. Now, what causes it? We're getting harder. Babies. Poor integument. Yeah. Yeah. Any other ideas? Constipation. CrossFit. That's a good one. All right, now the hardest question is, how do you explain these concepts to patients? So let's have a non-urogynecologist tell me how, maybe a resident, brave resident, tell me how you would explain pelvic organ prolapse to a patient. Yeah, that's a very nice way to explain it to a patient. Because this can be really challenging to communicate these concepts that can be a little bit abstract. So now we're going to get into what are, when I say the ligaments, what am I talking about? So when I say that, I'm talking about the cardinal and uterosacral ligaments, which we consider the apical ligaments that support the vagina and uterus. And we'll first talk about what is the structure of these ligaments. So this is a anatomic drawing that I'll orient you to. So this is looking down on the pelvis. The uterus has been cut away. The bladder has been cut away at the bladder neck. You can see the cervix in the middle, sort of helps you orient to it. Pubic symphysis is down on the bottom of the image, so that's anterior. You can see rectum hanging out at the top of the image, so that's posterior. And then you can see our apical supports coming in here, so the cardinal ligament and the uterosacral ligament. And you can see how it looks a little bit nebulous, the cardinal and uterosacral ligaments on this picture. And that's because they are a little bit nebulous, but we will get into what exactly they are. So first we have to go through like the basic anatomy. So there are ligaments, they have origins and insertions, and they do vary in different people. So when cadaver studies have been done of these ligaments, seeing where they actually go, they find that in the cardinal ligament originates at the anterior trunk of the internal iliac artery in about 1/3 of people. And then in 2/3 of people originates at the upper border of the greater sciatic foramen. So you kind of picture that in your mind where those are. Uterosacral ligament originates in 1/3 of people at just the cervix. And then in 2/3 of people, the fibers go to the cervix and vagina. So a little bit of anatomic variation here. Even a small subset of people, 4% in the cadavers they looked at, the uterosacral fibers originate at just the vagina and don't even connect to the cervix and uterus. And these are in cadavers without prolapse. So this is all looked at in normal women. And then the insertions of these two ligaments vary as well. So cardinal ligament can insert at the cervix and upper third of the vagina traditionally, but in 1/3 of people, some of those fibers even go to the bladder as well. Uterosacral ligament inserts overlying the sacrospinous ligament coccygeus muscle complex in most women, 82%. It inserts at the sacrum in less than 10% of women, and then about 10% of women inserts at various other places. So just something to keep in mind when we're doing surgery and we're thinking about, sometimes we tend to do the same thing every single time, but you just want to keep in some anatomic variation that can exist. Now, what are these ligaments made of? Well, you can do histological studies of these ligaments, look at them under the microscope and see what they're really made of. So when we look at the histology of the cardinal ligament, it is very interesting, actually. It has uterine vessels in it, adipose tissue, and nerves. So it has the inferior hypogastric plexus in it that has autonomic nerves in it that are going to go to your pelvic organs. Then the uterosacral ligament is quite different. It has two different portions that I'll show you what that means. If we're talking about the classical or superficial portion, this is the part that you see, like when you're doing surgery, you lift up on the uterus and you see that band that you identify as the uterosacral ligament. That's what we call the superficial portion. And that has mostly smooth muscle in it. Then it actually kind of continues with the uterine musculature, as you can kind of imagine as you're seeing those ligaments. And as you know, the appearance of those ligaments gets affected by the position of the patient, how much pneumoperitoneum you have, whether she's under anesthesia. So you can kind of start thinking of your mind how you've seen these look. And then there's the deep portion of the uterosacral ligament, which you don't see in surgery, but you do see on MRI. And we'll see some pictures of that. Some people might call these the rectal pillars or the perirectal fascia. In anatomy, there's often lots of different words to mean the same thing, which can get very confusing. And this part has nerves in it, so it has splanchnic nerves in it. And this is really the part that's going to establish the support of the posterior cul-de-sac, or what we call point D on the POPQ, for those of you who've learned about the POPQ. So this is a picture of a cadaver to go over some anatomy. And what I really want to highlight here is the cardinal ligament, and that it's not traditionally what you would think of as a ligament. So when you think of like the ligaments in your knee, that is not the same thing when we're talking about the word ligament and we say cardinal ligament. So let me orient you to this picture here. So uterus is being pulled up by an instrument here, kind of toward the middle or top of the screen. That blue star in the middle there is at the cervicovaginal junction where a hole has been cut in the vagina. The bladder has been removed here. You see pubic bone at the bottom of the screen. So you can imagine where bladder was right behind that. And then this white outline here is vagina. And part of the vagina has been removed in this picture. That's little circle-ish thing there, lemon shape, is the cervix. And then those white arrows show you where the cardinal ligament is. So that's extending laterally out from, you can see kind of the cervico-uterine junction area, fibers going to the uterus, cervix, and it's very broad. And now think about when we say we're clamping the cardinal ligament in surgery, this is the stuff that we're clamping. So the moral of the story here is the cardinal ligament is not a traditional ligament. We just use that word. Really, it's a mesentery. What is a mesentery? Well, it's a combination of different tissues. So it has, like we said before, blood vessels, fat, nerves, lymphatics, and no dense regular connective tissue like you would find in a knee ligament. So back to histology. These are actual trichrome stained slides of cuts through the cardinal ligament and the uterosacral ligament, so we can actually see what's in them. And when we do this staining, we see in the uterosacral ligament, we have mostly, we have a lot of adipose tissue, we have nerves in there, vessels. The cardinal ligament is gonna have a lot more vessels in it. So you think about that again, when you're doing surgery, going through cardinal ligament, you have all those little branches of vessels in the cardinal ligament, and you can see that here in the histology. Then there's that little inset in the bottom left. That is to show you a contrast to what dense connective tissue looks like in traditional ligaments. So this is really to highlight the difference between ligaments that we call the same thing that are very different. All right, so I had mentioned the two parts of the uterosacral ligament. So this is another cadaver image. This is a cadaver cut down the middle, and you can see fingers pinching the uterus there. And then we'll go over what all the parts are here. So in pink is highlighted uterus and vagina. Then the rectum is not showing up. Let's go. Okay, rectum has been removed, but where it would have been is highlighted in red here. Then that little black arrow is pointing to the uterosacral ligament superficial portion that you would see in surgery. And then that bracket there is showing that deep portion of the uterosacral ligament that you don't traditionally see with your eyes, but is still very important in support. And that part has been called vaginosacral ligament. We can also call it the classical uterosacral ligament. So you can see when you pull on the uterus there, it stretches out that classical uterosacral ligament part that you see in surgery, and that's made out of smooth muscle that's continuous with the uterus. And as we talked about, the shape changes as you pull on it, and that's going to become important as we talk about the biomechanics. But what is that stuff behind? That's that deep uterosacral ligament that when you pull more on vagina, you can see that that is sort of tensing up, but it's really hard to see with your eyes. All right, so if we want to study the ligaments, how can we do that? We've looked at gross anatomy, we've looked at histology, but now we want to know more about function. So MRI is a great way to study that. So with the dynamic MRI, we can actually look at the way ligaments function in different orientations, different situations. And this gives us a lot more information than cadavers because this shows us what it looks like in live women. So fixing of cadavers actually does affect anatomy. So it's not really as accurate to study function in cadavers. So that's one advantage of MRI. And then we can make lots of measurements on MRIs too. So then we can measure orientation and length of the ligaments and learn a lot about that. So this is a screenshot of a program called Slicer. Has anybody used Slicer? Okay, so this is new. This is a program where you can look at MRIs in various different planes. So you can tip the planes of the MRI, and then you can make 3D reconstructions of the organs that you see in the MRI. So it's really cool computer software that helps us make a lot of measurements and understand what's going on in the pelvis. So this one shows a reconstruction of uterus, which is uterus and vagina are in that pink peach color. Then the uterosacral ligaments are in that white color, and the cardinal ligaments are in that blue color. So you can see that 3D reconstruction that is made there. I think this is pretty cool to be able to really see what the orientation looks like in 3D. We'll see some more of this. Now, this slide shows a couple just slices of MRIs and then a couple of those 3D reconstructions, and I'll orient you to this as well. So if we start in the top panel, the A and B, first of all, in A, that little inset shows you the pelvic bone. So it helps you understand the orientation of these organs here. And in this one, the uterus and vagina are blue. So you can see that orientation there. The uterosacral ligaments are coming out in green, and the cardinal ligaments are coming out in that pink peach color. So you can kind of see those very different orientations of those ligaments there in 3D. And you can start to find these ligaments when you just look at MRIs. And it's good to practice finding them. Otherwise, they're kind of hard to find. But this shows you how you would find them. So in that bottom panel there, on the left side, that is an axial view of the pelvis. And you can see in those red arrows, those are the uterosacral ligaments coming posteriorly from the uterus. And the cardinal ligaments are with those little black arrows coming more laterally out from the uterus. And the bottom right, it just has the black arrows showing the the cardinal ligaments coming out laterally in a coronal view. So sometimes it takes a minute to kind of look at this and orient to that. But the idea of this is to start understanding the 3D geometry of these ligaments. Now, next, we're going to see how this looks in space when you look at it from different angles. So this is another cool thing that you can do with that program is you can make a model and then you can look at it turning in space. So here, white is pelvic bones. Pink peach is uterus, vagina. And right now you can just see cardinal ligaments in that aqua color coming out laterally. And we're going to start twisting this around. So first we're going to take the bones away so it's easier to see. And then we'll start turning that uterus around. And when we start turning it, you start to see the uterosacral ligaments coming out the back. And now we're tilting it a little bit more so you can see that orientation. So hopefully this helps you understand that the cardinal ligaments kind of coming out laterally like this. I'm going to say this a lot of times because this is like a point I want to drive home. And then uterosacral ligaments kind of coming out the back like that. And think about this when we're asking you to clamp those uterosacral ligaments, like in a vaginal hysterectomy, we're always telling you to kind of come from below and hook it up. That's because of this orientation. That's how you want to hook those ligaments because you need to get down and back there to get in that orientation. So hopefully you can keep this image in your mind and it will help you understand when you're doing surgery as well. So then you can go a step further and start to make models to study these ligaments. So this is where physics comes into it. And you can make kind of force drawings here where in the left side, just to orient again, you can see pubic symphysis on the left side, sacrum more on the right side of that picture. The uterus is in pink. And then in this one, we added in the levator plate. So the levator muscles in that aqua color. You know, I'm not talking as much about the levator muscles in this talk, but they are still very important and integrate in when we get to the model of prolapse at the end. So then you can see, we can draw a force line of the cardinal ligament, which is in blue in this case, and the uterosacral ligament, which is in pink, and going in those different directions. And then on the right side, we start to model what happens when we add in a downward pelvic load. So we're starting to think about prolapse, and that's that black arrow. When we're adding in that pelvic load, what happens? So that leads us to the question of what happens to the ligaments with prolapse? Like, this is our key question for urogynecology. So this slide gets a little complicated, so I'm going to go through it slowly. But this is what we call ligament dynamics. So dynamics just meaning movement, what happens with movement. So this diagram here, hopefully you're kind of getting used to these diagrams, but again, in white shows the pelvic bone. So it shows pubic symphysis on the left side, sacrum on the right side. The uterus and vagina are in hot pink. Cardinal ligament is in blue. Uterosacral ligament is in green. And now we're so used to these orientations of the different ligaments. So we can see what they look like at rest compared to what they look like at Valsalva. And again, these models are all made from dynamic MRIs. So this is real life, what happens when you measure this in women doing Valsalva in an MRI machine, and you're making models based on that. So this is real. So you can start to kind of see what's happening to the ligaments with Valsalva. And this is a woman without prolapse. This is just a woman with normal uterovaginal support who's doing a Valsalva. And you can see that cardinal ligament is lengthening and that uterosacral ligament is rotating. And then we can make these models that you see on the right side that illustrate how much, in average, the ligaments lengthen and rotate. So the broad take home here is that the cardinal ligaments lengthen with Valsalva, and the uterosacral ligaments rotate caudally with Valsalva. And you can kind of see, I mean, it does get complicated with all these different colors and lines and everything. It takes a little bit to like look at this to understand it, but that's the broad strokes of what's happening here. And when we look at women with without prolapse at maximal Valsalva, the cardinal ligament is actually going to elongate twice as much in people with, sorry, we're looking at people with prolapse. If we're looking at people with anterior prolapse, the cardinal ligament is going to elongate twice as much in people with anterior prolapse compared to posterior prolapse. So now we're starting to understand, different prolapses have different anatomy, potentially different causes as well. And then when we look at the change in length of the uterosacral ligament, it really does not change all that much when we're looking at controls and those with prolapse. So the lengthening is the cardinal, the rotating is the uterosacral. All right, now we can study some ligament properties in vivo. So this is an experiment that I'm going to show you that is, I think, very creative, that's going to look at the question of ligament laxity. So historically, people thought it was ligament laxity that was responsible for prolapse. And I heard that word laxity in the beginning when we were asking about prolapse. And that is a lot of times how we explain it. So let's test that. Is it really laxity that causes prolapse? Well, what we find is that it's really not as much laxity and more ligament length that's a factor for prolapse. So how can we measure this? Well, we can take women who are under anesthesia, put a tenaculum on the cervix, hook that up to a machine called a servo actuator that pulls a steady force on that tenaculum to pull out the uterus, hooked up to a computer to measure force displacement curves. Oh, we're getting into like major physics now. But it's going to make sense. And the diagram here, just to understand, the top left shows the woman in a high lithotomy position, as we generally would for surgery, and shows the orientation of how her uterus and cervix would be at rest in that left side. And then on the right side, it shows more where the uterus ends up when you pull on it. That dashed and dotted black line shows level of the hymen, which traditionally when we're measuring anything in urogynecology, we call that 0. Anything above the hymen, we call a negative. Anything below the hymen, we call positive. So that's how we're gonna show these results. And this is just another diagram showing what happens to the ligaments when you pull on them. And then this is an actual picture of how this experiment was done. Yes, these women are under anesthesia. This is not happening to women who are awake and feeling this. But it is just a regular tenaculum attached to the cervix. The weight of the tenaculum is suspended by that string. You see that string going upward. So that's to take out the factor of the weight of the tenaculum. And then it's hooked up to the servo actuator machine that, like I said, pulls this steady force on the uterus, so that we can start measuring how far uterus comes out with a certain amount of steady force. And we can make graphs and show what it does. Then on the left side here, you start to see this conceptual model of the ligaments straightening out as we pull on the uterus. And that's going to come into play when we get to our model. So yeah, that's that. Oh, and you can see the little ruler there on the machine, and that's how we are making those measurements. Okay, so then you can create these force displacement curves with this setup. So these are called hyperelastic ramp curves, which essentially just means force and displacement. So on the y-axis here is the force, so the force that is getting pulled with that machine. And then on the x-axis is where we actually measure the cervix location. That dashed black line in the middle is the level of the hymen, so that's what we generally refer to as 0. Anything to the left of that is above the hymen, or things that we call negative. Anything to the right of that is things that come below the hymen, or what we call positive. Each of these different colored lines is a different individual. So these show the individual measurements of where the cervix is going as you pull on it more and more and more. So you can see that they have different starting locations, they have different ending locations, but what happens when we calculate the slope here? So this little diagram is just showing again what the conceptual drawing of pulling on the uterus, what happens. And then this new darker dashed line is showing when we measure the slope of each of these curves. And that gives us what we call laxity or stiffness. So, in physics, that's called stiffness, but in, urogyn, probably we'd call it laxity. So then we can look at the difference in the woman who has the most prolapse, which is all the way on the right side, the woman who has the least prolapse, who's all the way on the left side. What's the difference? Well, it's actually not that different. So when you do the calculations, this shows that stiffness only accounts for 19% of the difference of point C that you see in these patients. So really, yeah, some, but not all that much. So stiffness or laxity is not the whole answer here. So that was a really important answer to that question of, is it ligament laxity that's causing prolapse? Now, some more fun things that you can see from this study are these bottom dash lines here, which these, again, the colors coordinate to, each color is a different woman, but then the dash lines are at the bottom showing where her cervix location was on a pop Q in the office. So that's when you just have her Valsalva and measure the location of her cervix, where's her cervix, compared to the solid lines are her under anesthesia when you're measuring it, and then when you're pulling on it. So you can see these are all over the place. So there's a big difference in what we find in the office and what we find in the operating room under traction. So that's gonna get to kind of the next topic here. of what we come up with the slat cord paradigm. So this is a basically theory that the ligaments start curved, as we saw from the models, the MRI models that we looked at earlier, and then they straighten with tension. And that's going to, again, come into our model of prolapse that we'll get to at the end. But that's kind of what this experiment is leading us to. There are questions on this because this one's really complicated. Okay. Yeah, it's the same observer. But they're not involved in the OR part of it at all. All right, so this gets us into some more physics, biomechanical properties. We can then describe the ligaments as viscohyperelastic. So what is viscohyperelastic? First, we have to understand what elastic means and what viscous means to know what something in between means. So I brought props because I was inspired by that radiologist that gave such an engaging talk. Something that is an elastic material is when you deform it, it's going to spring right back. So yeah, my example was my headphones. It springs right back. You deform it, doesn't matter how long I hold it out for, springs right back. So that's elastic. Something viscous, like this honey, is going to deform based on the force that's applied to it. And this is just the force of gravity. So this takes very little force. It's a very viscous material that's making it deform. If you can see the honeys then dropping to the bottom of the container, and it's not just going to spring back like those headphones did. Anyone who wants this honey can have it too, because I have too much. Something in between is viscoelastic. So I found this tiny preemie onesie, which luckily I don't need anymore. But if you stretch it a little bit, it'll come back, right? If you stretch it for longer, so you apply the force over a longer period of time, it's not going to come back as fast. And you can imagine if I then put a 1-year-old in this tiny preemie onesie, it would get really stretched out. If she wore it for a day, it's really never going to come back to its original shape. So that's more of how the ligaments act. They're more than viscoelastic, they're viscohyperelastic just because they have a little more elasticity than viscosity. But hopefully the props help make sense a little bit more. And then this example just shows a spring is like the ultimate elastic material because it springs right back, and silly putty is more of a viscous material that it gets displaced based on the force applied to it. Okay, so the next step of understanding the ligaments here is understanding what is normal when we do clinical assessments. So we've talked about MRI, we've talked about fancy machines attached to the cervix, but what about just in the clinic when we're looking at women doing Valsalva? What happens? What is normal? We need to understand normal to be able to understand what's abnormal. So I did answer this before, but would you expect a POPQ measurement in the office to be the same as a measurement in the operating room with traction on the cervix? Depends on her effort. Yeah, but in general, no. Okay. All right, so this is now when we look at women without prolapse, so women coming in for, say, IUDs or general well woman checks, whatever, that don't have prolapse, and we measure their point C, meaning, for those who are not familiar with the POPQ, that's measuring where the cervix comes to compared to the hymen. When you just have a woman Valsalva, you just say, bear down, push everything out, measure where the cervix comes to. And we can, actually map this on a bell curve and see what is average and where the standard deviation is in normal. So again, this is not going to work here, but I did have a little quiz here to ask what the average point C would be in women without prolapse. So we can just do guesses, just shout them out. Okay, give me a number. Okay, more numbers. We got a -1, -6. Those are very different. -4, -3. Okay, we got numbers. So the answer is -6 from a board certified urogynecologist over here. Yeah, so when we have women without prolapsed Valsalva, we're gonna, on average, measure that the cervix comes to 6 centimeters above the hymen. So it's still coming down, in traditional urogyne studies, they have sometimes defined failure of a surgery as the cervix coming a third of the way down the vagina. But that is within the range of normal. So there were definitely some flaws with how we used to measure failure in our studies. Then if we look at the 1 standard deviation from the mean, it goes from 4 to 8 centimeters above the hymen. So you just have to understand that to be able to define, what's abnormal. If you do an exam, a well woman exam on someone, and you have them Valsalva for some reason, I don't know, maybe you're just looking, have them Valsalva, and their cervix comes to 4 centimeters above the hymen, don't go telling her she has prolapse if she is not complaining of prolapse, because that is within the range of normal. And if you look at the 99% part of the bell curve, it goes between -11 and -2. So big range. All right, what about when we measure in the operating room? So in the operating room, she's under anesthesia, she's totally relaxed. We put a tenaculum on the cervix, we pull down on it and measure where the cervix comes to. What would we find if we did this on, again, normal women without prolapse, so women who are coming in for tubal ligations and ablations and things like that that are not prolapse related? And this is based on real studies of that. Where does the cervix come to when you pull on it? Let's have some guesses. Okay, we got a -2.
I think it's similar.
You think it's what?
I think it's like pretty close to what
Close to what they do in the office. Within a centimeter of the hymen, so we've got a wide range here as well. So the average is 0.8 centimeters above the hymen. Clearly, Dr. Patel has heard me say this many, many times. I'm a little bit of a broken record about it, but yeah. So you can pull a normal woman's cervix without prolapse down to a centimeter above the hymen. You can try this next time you're doing a DNC and you are pulling down on the cervix, right, to do a DNC. Just kind of keep in your mind, oh, whoa, this actually comes down more than I thought. And then you let go of it, and what happens? It springs back up, right? Because of the elasticity of the ligaments, it springs back up. Then if we look at 1 standard deviation, it actually goes between +2, so 2 centimeters below the hymen. It still can happen in normal women without prolapse. And in some women, you barely can pull it down at all, so only about 5 centimeters above the hymen. So this is, like I said, just important to know normal, to know what abnormal is. Just like you have to know for diagnosing diabetes in pregnancy, you have to know what the normal A1C is to know what abnormal is. So I think everybody should know this for prolapse as well. All right, so next question here is, how much force really is a physiologic load? So the load of a Valsalva, how much force really is that? And how much more force are we putting on with traction in the operating room? Hopefully this, yeah, it should. Okay, so this is a dynamic MRI. So this shows a woman doing a Valsalva, and you can actually see in real time what's happening to her organs. So she has a cystocele, so you can see the front wall of the vagina and the bladder dropping down. Her uterus is coming down as well, which you can see in the middle of the MRI. And then you can actually make measurements of how far that cervix moves with Valsalva. So this is just abdominal pressure, no external pressure. And we're measuring here where that cervix goes to. And we can compare that to, the prior studies we showed of traction in the operating room and where the cervix goes to. And we find that the force to move the uterus a physiologic distance, or distance of a Valsalva, is only 90 grams, or the equivalent of 3 ounces, which is the equivalent of the weight of a chicken egg. So it's really not much force that's happening with Valsalva. compared to force that you're going to do when you're pulling on the uterus. All right, so now comes the big moment of synthesis into a model for how prolapse might occur. So we're going to start here by orienting you to this diagram, which shows, just in very basic drawings, a pelvis cut down the middle, looking from the inside out. So pubic symphysis is on the left side of the picture here. Sacrum is on the right side of the picture here. In red, now the levator muscles come into play, which we haven't really talked much about yet. The black line is the vagina, and then the peach is the cervix and uterus. And those gray lines going toward the sacrum are just kind of general approximations of cardinal and uterosacral ligament. And we're showing what things look like at rest, no prolapse. There's curvature, remember, of those ligaments. You can see that they're curved. And what's important to now think about is vagina. So here, vagina is opposed, right? The walls are opposed, it's closed. When someone doesn't have prolapse, they've never had babies, walls of the vagina are opposed, meaning there's no atmospheric pressure that the organs are exposed to. There are balanced pressures on that vagina holding things, just with the effect of abdominal pressure, which is that blue arrow at the top. So then what happens when your levators start to fail, which is very common after childbirth? You know, we could do a whole another talk on what happens to levators with childbirth. But often there are levator injuries with childbirth. There can be levator avulsions with childbirth. And the genital hiatus, or the opening of the vagina, often starts to open up. What happens here is now there are unbalanced pressures, because now the walls of the vagina are not completely opposed to each other. They're now exposed to atmospheric pressure. And we still have the abdominal pressure every time we do bending, lifting, coughing, sneezing, vomiting, etc., which is that blue arrow. And this leads to higher pressure from the top that's no longer balanced by the bottom. Abdominal pressure higher than atmospheric pressure starts pushing down on these organs every time we increase our abdominal pressure, which is really a lot throughout our lives. Then the model goes on here that this then leads to the ligament straightening. So you can see how those, modeled little ligaments toward the sacrum there, you can show they're straightening, they're getting pulled on. This is the first level of the idea of how this prolapse might occur. And then the green on the bottom there is showing exposed vagina. So that's when the hiatus starts to open up, some of the vagina is actually exposed in the outside. And this really then, the abdominal pressure starts pushing down, and that can contribute to that anterior posterior prolapse as well. Anterior more than posterior, associated with the apex, apical prolapse. Again, whole nother talk there. So then, the very smart people at Michigan synthesized this into what we call the three-phase apical support theory. So the first phase here is the straightening of the ligaments that happens with what we just showed on the previous slide. Then the theory is there's tensioning on the ligaments. So once they're straight, then all of that extra pressure that's coming downward is leading to more tension on the ligaments, because they can't just go from curved to straight anymore. Now they're just getting tension. And the theory is that eventually over time that leads to structural change, so permanent change in the ligaments where they can't actually lift back up. So those are the three phases: the straightening, then the tensioning, and then finally structural change, which we think leads to adapted or remodeled ligaments. And when you look at, the proteins in the ligaments, which are other really interesting studies that you can section the ligaments and look at all the different like collagen levels and elastin levels and the changes that are happening. And a lot of these changes you can see with those studies. So we think this might be what is happening with the development of prolapse over time. So now I promised you some clinical pearls, and we have gotten to that time. Hopefully you've stayed with me through the science, but now we're gonna get to surgery. So we've learned about the importance of those apical ligaments in providing support for the cervix, uterus, vagina. And here we just have this really basic drawing of the uterus in gray, uterus and cervix in gray. Vagina is in a cream, and then the ligaments are also in gray. And just for simplicity here, we have 5 lines that we'll say, the strength of the ligament is divided into 5 here. Just stay with me. So this is what it looks like in a person. Then you do a hysterectomy. You're going to detach those ligaments from the cervix and uterus, right? You still see some of them are attached to the vagina because we're not detaching them from the vagina, but you have to detach them from the cervix and uterus to get the uterus out. So you can see here, to make it simple, if you're detaching 3 out of the 5, 3/5 of her strength of her support of her vagina, she's lost a lot of support. So what should you do next? Resupport the vagina. So what I teach the residents is the Richardson angle stitch that every single gynecologist can use to resupport the vagina. You absolutely do not need to be your gynecologist to do Richardson angle stitch to resupport the vagina. So this is where I want to end the talk of just going over how we do this stitch and putting a plug in to do this on every hysterectomy to resuspend the vagina in someone who doesn't have prolapse. So this is not an apical support procedure for someone with prolapse. This is a resuspension of the vagina for someone who you've cut a lot of her support. So we have these cut ends, and we can reattach them to the vagina. So I'm going to talk you through the Richardson angle stitch, which I have talked a lot of you through. But I'll show you the little model I made of it and then an actual video of it. So this little model that I made to orient you to it has vaginal cuff as the outer rim here. So we're looking at this from below as if you finish your hysterectomy and you're looking up at the cuff. Those spheres there are what we're modeling as the cardinal uterosacral ligament complex. And I always tag those when we take those bites at the beginning of the hysterectomy. I think probably most people tag them so that you could use them for various reasons. But yeah, as long as you have them tagged, it's really easy to find them. And the way you remember how to do a Richardson angle stitch is the mnemonic ACUP, A-C-U-P. So A is for anterior wall. So first you take a bite of the anterior wall from outside to inside, and this is pretty close to the corner. Then the CU is for cardinal uterosacral. So then you take a bite of your cardinal uterosacral complex. And this is a skimming bite. So this is a small bite of the cardinal uterosacral, and we'll talk about why. And then the P is taking a bite of the posterior wall from inside to outside on the cuff. And then we tie on the outside. And we do this on both sides. Now, we don't want to do a big bite like that because then you can see we're tying on the outside. Then there's a lot of that cardinal uterosacral ligament that we're not including in our bite. That's not going to be in that tie if we take this big bite of it. A lot of it, okay, all that stuff then is not going to be reincorporated into the cuff. Whereas if you take this skimming bite, then most of it is going to be reincorporated into the cuff. Hopefully that makes sense. And then finally, the last thing I have here is a video of the Richardson angle. Vicryl, vicryl, yeah. So that's your anterior, that's the A, that's your anterior bite into out. This is the CU, this is your skimming bite of the cardinal uterosacral complex, top down. And then the P, the posterior bite from in to out, again, close to the corner. So that you can then tie on the outside and you have reattached those disconnected cardinal uterosacral fibers to the cuff, and you're giving her back her support that you cut out. Really, really simple thing. Absolutely everyone can do. You can do it from above too. You can do the exact same thing from above. Obviously, this is showing from below. And then what I do is I use one stitch on my right side, and then I use the second stitch on my left side, and then use that to run along the cuff too. So this is your cuff closure. And I'm happy to share this video too. So. And when you do this, you do see that then the cuff really, you can pull it out towards you, of course, and then the cuff really sucks back up once you let go of it because of the elasticity of those ligaments. So thank you for listening. I found this old photo from 10 years ago when my residency class, we were very excited to be second years. And I had no idea I was going to be a urogynecologist. Definitely did not think I would be up here talking about biomechanics of apical ligaments 10 years later. So yeah, to the residents, you have no idea what is ahead of you. But I'm happy to take questions. Dr. Pennycutt.
Oh, of course I have questions. Thank you. All right, my question is really about the widened genital hiatus. Okay, and it's a two-parter. All right, so the first parter is there's a camp of urogynecologists at UPMC that believe that if a woman has, or if a patient has a widened genital hiatus, that we should immediately go to sacrocolpopexy because they're going to fail a native tissue repair. And, you know, we don't have good evidence for it, but it makes sense with like the levator avulsion, why people have a widened genital hiatus. What are your thoughts on that?
That makes no sense to me.
Okay.
Because that's not based on anything. That's made up.
Right.
There's no evidence for that.
So if someone comes in with a GH of 6-7, we can offer a native tissue repair.
Yeah.
Yeah. Okay.
Yeah. And we have to do a posterior repair perineorrhaphy
Yes.
to narrow that genital hiatus. Yeah.
Okay. Second part. So in perineal laceration clinic, I have young patients are coming in. Many of them do have widened genital hiatus because their repair has broken down. And I often tell them, oh, I don't think that we're preventing prolapse or preventing pelvic floor, but we're getting you into treatment sooner. But these patients who have a broken down perineal repair, which we know happens, it's healed, and then I take them back for a revision. I narrow their genital hiatus. I might do a posterior repair on them. Am I preventing prolapse by narrowing their genital hiatus?
That's a great question. I think maybe we are, based on the studies that were done at, I think, Hopkins on the postpartum women who have widened genital hiatus right after birth, have widened genital hiatus later on. And with this, model that does contribute to prolapse because of the unequal pressures, we probably are kind of lowering their risk by narrowing that.
So should I, if I have a patient who comes in with a genital hiatus greater than 3.5, 4, should I be saying, hey, we should be taking you back for a revision?
Maybe you want to do a 30-year-long study on it.
Yeah. All right. Interesting.
Thanks so much, Caroline. That was just awesome. One quick question I have is, I love the studies that were done about the sort of laxity versus length. And of course, it's over time. These things happen dynamic across women's lives. Has anyone done that? Just the sort of normal experience of the uterus and the uterosacral ligaments, across some time span. We know that, over time, our bones become shorter because they lose water over decades. Has anyone looked at this over decades? Because there's, this is just one point in time.
Yeah, not that I know of. I have not heard of that study being done. The only thing I can think of that it's sort of like that is there was at Michigan, they did an aging study on, they looked at nulliparous young women versus nulliparous older women and looked at the levator bowl shape and measurements. And that changes with age. So we know that the levator bowl actually does sink with age. Just like all of our muscles change with age. So that probably has something to do with it, but I don't remember them really looking at the ligaments necessarily in those studies.
Yeah, because it seems like there would be age changes that,
Yeah.
But great presentation. Really appreciate it. I think we should cut it off. We'll take 5-minute break and reconvene for M&M at 8:25. Thanks so much.